Welcome to the Cafe Culture podcast, a season of discussions on culture, politics, philosophy and science.
At a talk recorded on the 17th of November 2014, Richard Thompson discussed whether healthcare decisions should be more accountable.
Thank you very much, Janice, and thank you very much for inviting me. Now, I'm going to kick off by circulating a little questionnaire. Now, this isn't a test, but have a look at this and see what you think the answers to these questions might be. I'll just give you a couple of minutes to run through those once they've got round, and that will give us something to kick off your thinking before I go into the sort of main talk. And I'm really looking forward to hearing your thoughts on all of this. So I suppose what I'm really looking forward to is finishing my talk and getting to hear your views. I'll just give it a break while the questionnaires are going on. Have we got everyone? Okay, brilliant. So I'll just talk you through the questions, and then by the time I've talked you through, you can have answered them, and I'll tell you what the answers are. As I say, this isn't a test. We're not going to mark them, and we're not going to have a league table of you at the end of all of this. So the first question is, what percentage of patients discharged from hospital say they were involved as much as they wanted to be in decisions about their health care? Okay. And there are alternative answers to each of these, as you can see. The second question, what proportion of their patients do doctors believe want more information on their treatment? Okay. You'll see there's a theme here, and you'll be surprised at some of the answers to these, I suspect. The third question is about patients with diabetes. What proportion of people with diabetes having an agreed care plan with a health professional which discusses their individual needs to set targets? So what proportion have an agreed care plan with their health professional? There's another side, second side. What proportion of people make decisions about their health care? Making decisions about their health care answered more than one question correct in a brief knowledge test. What that question covers is doctors were asked what they expected patients to know about, 3 or 4 key things, in making a decision. Then after the decision, they were asked if they knew those items. What proportion of people take their medicine as prescribed? And finally, what proportion, this is a slightly complex one, so I'll talk you through it. What proportion of people with severe arthritis of the knee or hip that was appropriate for joint replacement, knee replacement or hip replacement as defined by surgeons said they'd definitely want that knee replacement or hip replacement? Okay. Sorry, wouldn't. Well spotted. That's just checking you're listening as well. That's good, isn't it? Okay, let's go through those, and I'll tell you what the answers are, and also where the source of the data come from, and then that'll give us a good route into what I'm going to be talking about. So the percentage of patient, you can mark your own, don't need to pass it around, and as I say, there's no tests. And the answer to the first one, the percentage of patients discharged from hospital, is 55%. Okay. And that was from the 2012 survey of patients, NHS survey of patients. So only 55% said they were involved as much as they wanted to be. In contrast to that, when doctors were asked through an online survey, through a thing called doctors.net.uk, what proportion of their patients they believe want more information on their treatment, 65% of those doctors said only a minority. So some disparity between what patients were reporting and certainly what doctors felt about their patients' needs. The third question, proportion of people with diabetes reporting having an agreed care plan. This is from a survey done by Diabetes UK in 2011, which sought to explore what they felt were essentials for good diabetic care. So one of those essentials was this: patients have an agreed care plan with their health professional, and only 35% of patients had that essential component in place. Moving over the page, the brief knowledge test, what proportion of people making decisions about their healthcare, that's 50%. So half of people making decisions about treatment options couldn't answer straightforward questions that they ought to have known the answer to in order to make the right decision. The proportion of people that take their medicines as prescribed, well, there's two correct answers here in a way. 35% of diabetic patients only cashed enough prescriptions to take enough treatment for a year in a survey done in Scotland. And in general, if you look at the way that prescriptions are cashed in this country, about 50% of prescriptions 50% of medications that are prescribed are not taken, and something like 1 in 20 patients don't even cash their prescription. Okay, and the proportion of people with severe arthritis of the hip or knee who would have been appropriate for surgery, joint replacement as defined by surgeons, 50%, when given the right information to support their decision, said they actually wouldn't want joint replacement. Okay, how did we do on that? Anyone get 8 right? Probably not, because there was only 6. Anyone get 6 right? I should have told you what the prize was. The prize was that anyone who got 6 right could come and deliver the talk, and I'd sit down. But hey, I suppose I've got to get on with it now. Okay, let me say a little bit about myself and where I'm coming from. So my background is I'm medically trained. I worked in gastroenterology, guts and livers, for several years before moving into public health. Public health is concerned with the health of populations rather than necessarily the health of individuals. And throughout my career in public health, both working in the NHS and working in academia and research, I've been interested in quality of care and how we can improve the quality of care and what impact care has on the health of populations as well as individuals. And over the recent years, much of my work has been around this thing called shared decision making. How do you involve patients in decisions about their own treatment? And that's what I'm going to talk you through today. Just to get a sense of the audience, how many of you have got any sort of clinical background? Okay, a few. Okay, how many of you work in healthcare? Not so many, so interesting. Okay, and how many of you are patients? Yes, I expect to see most hands go up there, if not all. I'm one. And you will have all experienced at some point some sort of interaction with healthcare and with healthcare professionals, if not for yourself, for members of your family. So you will have been observers of these sorts of interactions, and I hope we'll get your thoughts and ideas and your experience coming out in the discussion. But what do we mean by shared decision making? So we need to think of consultations and discussions between healthcare professionals, doctors, nurses and other healthcare professionals and their patients as fitting on a spectrum. At one end of that spectrum is paternalistic healthcare. That's the doctor knows best and the patient does what they're told. I'm pleased to say we've largely moved away from that, but there's still some of that undoubtedly goes on. But 20, 30, 40 years ago, that might have been the traditional approach, that the doctor was seen as the person who made the decision on your behalf because they were the expert. At the other end of the spectrum, on this spectrum, is informed decision making. And by informed decision making, we mean that in this context, the doctor or the health professional provides the information that the patient might need to make a decision and then just leaves it to the patient. So the doctor or professional becomes, if you like, a technician. They transmit and provide information, and you as a patient make that decision about what you want, regardless of what the professional may think. Okay? And then in the middle of that spectrum is what we see as shared decision making. So shared decision making is when the clinician and the patient make a decision together. Okay? But it's not just making a decision together, it's an approach where patients and clinicians make a decision together using the best available evidence. So it has to be a well-informed decision. There's no point in making a decision together if you don't have the information necessary to make the decision. And a good shared decision, therefore, can be defined as having several characteristics to it. Firstly, from a patient perspective, the patient has the right sort of information to decide between different options. That doesn't mean they have to be a clinician, or they have to know everything that the doctor or nurse knows, but it does mean that they need to know what the options are for any treatment. They need to know what the risks and the benefits of those options might be, and what the consequences of those options might be for them as an individual. And they need to know what's important to them in making that decision. And then a good shared decision is, by definition, if you like, one where the patient is sufficiently well informed to understand what those options are and makes a decision that's consistent with their own individual values and preferences. Okay, let me tease that out a bit with some examples. So a commonly used example is the choices that are available to women who have early breast cancer. So put simply, if a woman presents with early breast cancer, with a lump in the breast, there are broadly two options. One is to have the breast removed totally, a so-called mastectomy, and the other is to have the lump removed, so-called breast-conserving surgery, or sometimes called lumpectomy. Now, the survival from either of those operations for women with early breast cancer is exactly the same. So there's no choice, there's no reason to choose one or the other based on survival alone. But the consequences, of course, are very different. And the implications for treatment are very different. So if you have the lump removed, you're going to need radiotherapy and other consequences that arise from that. So you're going to have several weeks of radiotherapy. Whereas if you have the breast fully removed, that brings with it the confidence that the tumour has been removed and there's very little chance of local recurrence. If you have the lump removed, you have to have radiotherapy and there may well be later local recurrence. But of course, you've retained the breast, and that may be incredibly important for an individual woman. Now, the point about all of this is that there's no right answer to this, and it would be completely wrong for the surgeon to say to a woman with early breast cancer, you should have a mastectomy or you should have a breast-conserving surgery, because each individual woman will have different perspectives on that. So some women will say, I'd much rather have the breast removed and have the confidence and understanding that that's not going to come back in that breast. Other women might say, it's really important for me to retain my breast, and therefore I'm prepared to accept that there are some other consequences of that I'll need to go through radiotherapy and that I'll need to have follow-up to see whether that comes back. But at the end of the day, as I said at the beginning, the overall survival is the same. So that's a really good example of what we call a preference-sensitive decision, a decision that it would be wrong for the clinician to make on your behalf, and certainly one that you should be involved in making for yourself, but one where different women will have different preferences in terms of the risks, the benefits, and the consequences of that decision. And the reality of this is, although that's a relatively straightforward and often quoted example, there are very few decisions in clinical practice where there aren't alternative approaches in the management or treatment of your condition. So in very many examples, it would be totally appropriate for you as a patient to be involved in that decision-making process, because what really matters to you is what ought to drive that decision. So other examples might be, for example, a woman who's had a previous birth, delivered a previous baby by caesarean section. There's a choice at a subsequent delivery as to whether to go for an elective caesarean section, have a planned caesarean section, or to go for a trial of labour. And again, the outcomes are much the same, but if you have an elective caesarean section, You know when you're going to have it done. You don't need to worry about any risks that might occur in trying a natural birth, and the fact that you might go for a natural birth and end up with a cesarean section anyway, and that might be a more urgent thing. But actually, most people who've got a cesarean section can deliver quite normally on a second delivery. So again, you can see what the risks and benefits are and what the balances are. But it's not just about these, what you might call episodic decisions, the one-off things. Shall I have a hip replacement or not? Shall I have a C-section or not? But it's also important for people with long-term conditions. We're repeatedly making decisions either on our own, in our own self-care, or in consultation with our doctors and nurses as to what we should do next. So most, if not the majority of interactions between patients and the health service involve decisions of some sort or another, even if that decision is, shall I keep taking my tablets tomorrow? Shall I do more exercise tomorrow? So the fundamental basis of this is, how do we ensure that patients are more actively involved in those sorts of decisions? And one way of looking at this is that, if we think of shared decision making, we think of it as two experts. The expert is the clinician, who will know about diagnostics, know what the treatment options are, should know what the risks, benefits and consequences of those treatments are, and should know what the likely outcomes are. But you as a patient know your own illness. You know what you've experienced. You know what's important to you, what you're looking for from that treatment. Is it longer survival, or is it better quality of life, for example? And all of that needs to be put in your own personal social circumstances. So different choices will have different implications for your day-to-day life, and that's why it's important that you're involved. You'll have different attitudes to risks, and you'll have different values and preferences. And good shared decision-making supports you in making the right decision for you based on what's important for you. Okay. So what's the problem? Well, the problem is two levels, I think. The first is the problem of poor decision quality. So if patients are unaware of the options, or unaware of the outcomes, or unaware of those risks and benefits, then how can they engage with making the right decision? And if clinicians are unaware of what's important to the patient, what's important in your day-to-day life, and don't allow you to engage with that discussion and to understand what the implications of any choice might mean to your to what's important to you, then you're going to have a poor quality decision. The second level, and we'll come back to this, is how do we actually get this to happen routinely in practice? Because as you've seen from some of the questions you've looked at already, we're not very good at doing that at the moment. So although I might stand up here and make a very good argument for shared decision making, it's not something that's happening as routinely as perhaps it should be. So why do we do it? Why is shared decision making important? Well, there's obviously the fundamental ethical argument which we work through, which is that it's your body, it's your circumstances, you live with the consequences of the decisions that are made, so it's absolutely ethically correct that you should be involved in that decision. And some people would say that's sufficient to justify engagement in decision making. But there's another angle to this argument, and that is that there's increasing evidence that being involved in decisions is good for patients, it's good for clinicians, and it's good for the service. So, for example, a review of all of the literature, all of the published literature around patient decision aids, tools that patients can use to help support them in making decisions about their treatments, which was revised only earlier this year and had 119 different trials of these decision aids, and I'll say a bit more about decision aids in a while, showed that patients who used those and were involved in using those had better knowledge, they had more accurate perceptions of risk, they felt better involved and clearer about what was important to them. Fewer of them were undecided about what the right decision for them was after using such a decision aid. And increasingly, the evidence is showing that Using these aids, these tools to support shared decision making, leads to patients who consistently make decisions that are themselves well informed and consistent with their own values. But being involved in decision making has other benefits. One of the questions we looked at was adherence to medication and how poor that is. Why is that? Well, one of the arguments for that is that people aren't sufficiently understanding of why they're taking the medication in the first place and what the benefits and risks of that might be. And if patients are involved in decisions about their medication, then the evidence shows that they're more likely to take it. One example of this is that we find that patients who take medication for high blood pressure, that's a particularly difficult area where patients often don't take their medication. What's the consequence of that? Well, apart from the fact that by not having good treatment for your blood pressure, you raise the risk of subsequent heart attacks and strokes later on, which is the reason for controlling the blood pressure in the first place, there's another consequence here. In reality, what happens is that many patients don't take their medication because they're not sure why they're taking it and they don't understand the benefits. Often they don't take it because they've got side effects and they don't discuss those with their doctors. And more importantly, arguably, most people who don't take their medication don't tell their doctors they're not taking it. So they go back to see their GP measures their blood pressure, your blood pressure is not controlled, what are we going to do? We'll add another tablet to control it. So the consequence of bad decisions around blood pressure control are the patients don't take their tablets, their blood pressure isn't properly controlled. When they go back and see their GP, the GP gives them even more blood pressure tablets to control their uncontrolled blood pressure, which they don't take as well. So the whole thing doesn't help anybody in that context. So shared decision making improves adherence to treatments and also helps people to make real and informed decisions about not taking treatments. Okay, in long-term care, in patients with diabetes, with chronic obstructive airways disease, with arthritis, there's increasing evidence that patients who are involved in decisions about their care and manage, let's face it, manage their care on a day-to-day basis anyway, have better outcomes. So diabetic patients who are better informed and managing their own care more effectively on a day-to-day basis have better survival and they have less of the adverse consequences of diabetes as a result. So we've got a good evidence for involving patients in decisions, and that's growing all the time, regardless of the, as I say, the underpinning ethical arguments for this. So you might ask, well, so why aren't we doing it? Why are those figures that you saw in your questionnaire so poor? One of the things we've done over recent years is do a lot of work around implementation. So I can talk about the evidence from research, but does that lead to people behaving in the right way within the service? Does it mean that your doctors and your nurses are involving you more in decisions, or at least as much as they should? And we've done a number of studies over recent years, and some consistent things come out of that, out of the work we've done and out of work done internationally, as to what the barriers are to this happening in practice. One is, and this is a difficult one, many doctors and clinicians say, we do this already. Well, you've seen some of the data. Clearly they don't do it already, otherwise we wouldn't be getting patients reporting that they're not involved as much as they would like to be. So there's an issue about understanding, awareness, and knowledge and skills in clinicians. Often those same clinicians say, it's too complicated and it takes too long. And that's a barrier, perception that involving patients in decisions takes longer than perhaps saying what you should do is X or Y. The evidence for that is pretty limited, actually. And the studies I talked about in use of decision aids suggest that the consultations that patients have with their clinicians when they've used one of those decision aids are no longer than the normal consultation. However, it would be wrong to say that there may not be implications for lengths of consultations, because it seems common sense, doesn't it, that if you're going to have a more in-depth discussion with your clinician, it's going to take a bit longer. But I think increasingly what we are seeing is that that's likely to lead to fewer problems in future. So it's an upfront investment that might take a bit more time, but is actually to the benefit of the patient and the service and clinicians, who may not need to see you on repeated visits because you're better informed and making the right decisions from the beginning. Another barrier is what we might call accessible knowledge. So to be able to make these decisions, both patients and clinicians need to have the right sort of information at their fingertips at the right time. So when you're sitting in a consultation, you want your doctor to be able to give you that information in a way that's understandable. Your doctor wants to have it there at the right time, and you need to be able to use the decision in the right time and the information in the right time and the right place to do that. And that can be a challenge, and I'll come back to that. There's the issue I've already touched upon around skills and experience in clinicians. Many of them don't feel that they fully understand what this means in practice. Some of them, of course, do, because they say we do it already, and they may or may not be right into that. And then there's some wider challenges about how do we get this to fit into clinical practice? Will we have to change the way we deal with patients, the way we interact with patients to make this more embedded? Will it involve different ways of delivering care in order to ensure that patients are properly involved in that process? So what I thought I would do is just very briefly then give you some findings that have emerged from our work around implementation as to what you can do and what's needed, and also a bit more about those barriers in order to make this happen more. And then I'll be very interested in your perspectives as potential and actual service users as to what you think could make this better for you as individuals or as families. So one of the key bits of learning was attitudes trump skills, trump tools. One of the big challenges here is changing attitudes of clinicians. We did I'm almost embarrassed to say this, but we did a study ourselves recently where we interviewed some clinicians about a particular decision that patients were making under their care. And the interview was to try and understand what the barriers were to these decisions. And we interviewed patients who'd gone through those decisions, and we interviewed clinicians who'd supported patients in going through those decisions. And one of the clinicians, one of the doctors who was interviewed, was asked how he felt about involving patients in decisions about their care. And in a recorded interview, he quite openly said, "Most of my patients are too stupid to understand." So we've got a bit of work to do in certain circumstances. I'm not suggesting that all clinicians are like that, but there is still a body of people who you might think have not bought into the concept of patient-centred care. So what we found in the work that actually clinicians do need support into developing these skills for person-centred care and shared decision-making. They're often not bad at saying there are options, there are different things that we can do here. They're maybe not so good, and certainly can be improved in the issues about risk communication. What are the risks and benefits, and communicating that in a way that we can all understand. And actually doctors and clinicians themselves aren't very good at understanding risk, so that's another issue. What they tend not to be good at, and they struggle with, is understanding what's important to the patient in front of them. And when we designed and developed some skills training for clinicians, which involved them in doing role play work around shared decision making, and we broke that down into component parts. And the sort of light bulb moment for many clinicians was when they got into a role play with a patient, and they started to talk to the patient in this role play setting about what was important to them. And they realised that actually they didn't very often do that with their patients. They tended to either make assumptions about what was important to their patient, or, as we all do to a certain extent, it's part of human nature, we think about what would I do in this circumstance, which of course assumes that what I would do is what you should do. It assumes that my preferences and values are the same as your preferences and values. So that was the big challenge there, and that was where we felt there was the most benefit to be gained from some of the skills training we're introducing. So certainly there's a need for more skills training amongst doctors, nurses, etc. We've introduced that into the undergraduate curriculum, and there's work to be done to expand that. The second thing that was important and that does have value is, and I've already mentioned it, patient decision aids. These are tools that allow a patient, and traditionally they've been DVDs, booklets, online tools that provide the sort of information that you might need in order to weigh up the risks and benefits of the options that might be available to you. And the clinician might see you in clinic and refer you to have a look at this tool and come back and make a decision. They tend to be time consuming, and obviously they can't be used within a consultation because they take time to work through. That's not to say they don't have value, and most of those studies that I mentioned earlier were exactly those sorts of aids, things that people could look at online or take a booklet home or watch a DVD that would help them with their particular individual decision. But there wasn't anything that you could use in the consultation. And one of the things that we found in working particularly with our skills training was that it was really helpful if you could get a very brief summary on a single side of paper or a couple of sides of paper that sort of listed the options and the key risks and benefits. And that was really important for two reasons. One, well, possibly three reasons, maybe more. One, that it meant that the information was accessible at the time of the consultation to both you as a patient and to the clinician. And particularly for general practitioners whose next patient may be presenting with something completely different to the one they've just seen, we can't expect them, can we, to hold all of that information in their heads? It would be impossible. So it's very valuable to be able to have that information accessible to you within the consultation. The second thing was, and this was intriguing when we did our role play work, is that by having that sort of single sheet of paper with the information on, it changed the dynamics of the consultation. So the clinician would turn around and talk to the patient, would you believe, sit next to them rather than over the desk. And that led to a different dynamic in the consultation. That was really important. And the third thing was that it was something that patients could take away, they could write on, it could become a living document, they could bring it back for a subsequent consultation. So one of the challenges, I think, is to develop more and more of these, what we call brief decision aids or option grids, things that can be used within the consultation. We also found that one of the other key issues, surprise, surprise, was the importance of clinical champions, leaders who within their clinical teams would say, we must be doing this, we should be doing this, and could galvanise their clinical teams into doing shared decision making and taking it seriously. So it's important to have clinical leaders who buy into this and are seen as role models for others. There's also the challenge of making sure that the whole team buys into it. So going back to the example earlier on of early breast cancer in women, you don't just see a surgeon, you'll see an oncologist, who might deal with medication treatment, a radiologist who might deal with your radiotherapy, you'll see nurse specialists who will advise you. If you get a different approach from each of those, if they're not all bought into the idea that this is a decision you should be involved with, you can end up really quite confused. So the teams themselves have to work together on this. And what we found was that different teams had different incentives for doing this. For some teams, it was just driven by, we want to do absolutely the right thing for our patients. For some teams, it was, we seem to have too many women, one of our surgeons said to us, too many women who want mastectomy. Well, how do you know? What's the right rate of mastectomy compared to lumpectomy? Unless you know what's important to the women who are making those decisions, you can't decide what the right rate is. And so it was a way of exploring that. Others, it was because they were developing something new and it was a real opportunity to build that person-centred shared decision-making in from the beginning. So, for example, locally, the introduction of the midwife-led unit was a real opportunity for the obstetricians to build in patient engagement in decisions about whether to go to the midwife-led unit or standard care or home delivery at an early stage. And the other thing that came out of this was the role of the patient and the public in this. So this isn't all about changing the behaviour of doctors or changing the skills and knowledge and understanding of doctors. It's also about, well, how do you as patients, how can we support you? What skills might you need to be able to interact with your clinicians in a different way. For example, one of the things that's commonly found is that older patients are less inclined to want to engage in those decisions. Now, is that because as you get older you feel less inclined to do that? I don't think so. I think probably it simply reflects an experiential background, that this is a health service I grew up with where it was expected that doctors would tell you what to do, and I've grown up with that understanding, and so that's what I come to expect when I go and see a doctor. And sometimes if you go and see a doctor who in that circumstance who starts to want to engage you, you might feel, this is very odd, I haven't experienced this before, what does this mean? But also, even those who actively want to engage with these discussions with their doctors can find it quite difficult for a whole variety of reasons. We might talk about that. So that we need to find ways that also support patients in engaging in those equivalent discussions. Going back to what we were saying earlier, two experts in the room, how do we ensure that the expertise of the patient and the expertise of the clinician are given equal weight? One of the ways we explored this was very simple and straightforward, but seemed to be quite effective, was to give patients questions that they might ask, or at least questions that they might seek to get the answers to in a consultation. One of those was an ask three questions approach, where it was suggested that a patient going to a consultation where there was a decision to be made might have in their mind three questions. What are the options? What are the risks and benefits of those options? And how can we make a decision that's right for me? That's not to say that patients have to go in with those three questions and ask them directly of the clinician, though there's no reason why they shouldn't. But even having those in your mind and thinking through, have I got these answers, and is this consultation taking me down that route, can help. Now, it's more complex than that, and that's a rather simple solution to a more complex problem, but nonetheless one that helps. And we found that if you make those questions available in the clinic, if you put them into appointment letters, if you have posters around the clinic and business cards and so forth, interestingly, on the one hand, it helps patients to think differently about their consultation, but it also means that the clinicians think differently if they know that the patient in the waiting room has got three questions that they've been given that they might ask them. So there's a knock-on effect on clinicians as well. But I think there's a lot more we can do to support people in better engaging with open and equivalent discussions with their clinicians, and I'd be very interested to hear from you about that. And then finally, there are a lot of issues to do with the system of healthcare within which this happens. So it's a challenge always in healthcare for everything to be aligned in the same way. And actually, many of our policies and national approaches, whilst there's a lot of support for shared decision-making, person-centred care, etc., and if you read current health policy, or if you read what the General Medical Council says, or what the Royal College has said, you'll say, well, it's all in the forefront of their minds. But then that has to actually be delivered on the ground as well, and that can be difficult. So at the moment, for example, we have targets for treatment of cancer within certain time intervals. And if the system doesn't deliver that, then somebody in the management chain turns around and says, you're not getting patients treated as quickly as you should. But that takes no account as to how long it takes for a patient to get to the stage where they're ready and willing and sufficiently informed to make that decision that's right for them. And on occasions, undoubtedly, that will mean that patients who aren't ready to make that decision are being pushed into that decision in order to meet a health service target rather than an individualised approach. And similarly, there are other tensions within the system. And we don't yet, although the Royal Colleges, who are responsible for postgraduate education, the GMC, who are responsible for overseeing our undergraduate education, although they say these things are important, do they really follow that through? And I'm not sure yet they do. So I don't see postgraduate training, clinicians in postgraduate training getting their membership of the Royal College of Surgeons or whatever, failing to get that because they're not patient-centred. They may fail to get it because they don't know the surgery, but they don't fail to get it if they're not patient-centred. So again, we're not necessarily embedding what we need to do in the system to ensure that shared decision making actually bites. Okay, I think that's probably good enough for now and more than enough from me. And what I'd really like to do now is to get your thoughts and ideas on that and your feedback on what I've been saying today. So thank you for listening.
Cafe Culture North East is supported by Newcastle University, Peels and the British Science Association. We're also supported by Ginger's Cafe in Dance City, who host the events.